Is there any other data from the 2024 San Antonio Breast Cancer Symposium that you're excited about?
Well, yeah, I mean, the big one that everybody's very excited about. I mean, there are two things really. They're both New England Journal papers that came out, I think. The first one had to do with systemic therapy. So, imlunestrant, which is an oral SERD combined
Mhm.
with abemaciclib, seems to have benefits. See, our big problem in breast cancer is what to do after, in ER positive in particular, well, in ER positive metastatic disease, what to do after progression on CDK4/6 inhibitors. We're not quite sure
Right.
what. And I think that, there's some data that was presented, initially as a late breaker, that suggests that giving DXD early, in people who progress really fast, like within 6 months, it still
Mhm.
has benefit there. So I think that's going to drive everybody just give an ADC at that point.
Mhm.
But then you have the people who progressed after like five. The nice thing with breast cancer is that you've got this whole cohort of people who can do very well for like 3, 4, 5, 6, 7 years on a
Right.
CDK4/6 inhibitor in the first line. And
Right.
those people, maybe if they have an ESR1 mutation, would get single agent SERD. I think that's kind of where that's going, or
Mhm.
maybe something else. It's really that in between group. What do you do about them? We obviously do genetic sequencing,
Right.
look for PI3 kinase mutations, ESR1
Right.
mutations, and base our therapy on that. But there was a really nice Ember 3, which is a randomized trial of CDK4, about two-thirds had CDK4/6 failure. One group got standard of care hormonal therapy, whatever it would be in the second line.
Mhm.
Second group got oral imlunestrant as a single agent, which
Mhm.
didn't really work unless you had an ESR1 mutation and seemed to
Mhm.
be benefit. And then the third group got imlunestrant and abemaciclib, so ADC after ADC. And
Mhm.
that group actually, even in the people who had prior PI3, prior CDK4/6,
Right.
had a PFS of about over 9 months, which is more than
Oh,
anything we've ever had in this disease. I mean, usually we're thinking about 5 to 6 months from
right.
like PI3 kinase inhibitors and stuff like that. And it's 9.2 months. So it's longer than anything we have. So it's likely, and it was in the null patients too, it was in the, not null, the ESR1 wild type patients. So it's going to be really interesting to see what the FDA is going to do about the label. It's going to get a
Mhm.
label. Is it going to label the oral just for ESR1 mutations and the
Mhm.
combo for everything? We hope. Is everything going to be ESR1 mutations? It's really going to depend on the label and how the guideline, the NCCN, decides to put it in the guidelines. Another guideline path
Right.
is the path. It's going to be really
Right.
interesting to see what happens because I think in ESR1 wild type in particular, I think if we
Right.
had that combo, I think it's all oral. It's not shots, which people hate to get. They don't like fulvestrant every month. And to me, that was probably the big abstract in San Antonio that everybody liked. There was another one, though, that had to do more with local therapy that I thought was really
Okay.
fascinating. So, this is one of several trials now where they're eliminating sentinel node dissection. And for patients with, lower grade T1C tumors,
Mhm.
it appears, regardless of your menopausal status, that if you have like, grade 2, you can avoid sentinel dissection. You have the same progression-free and overall survival, in a fairly well-done trial.
Yeah.
There's several trials like this now.
Hmm.
And even were some patients with T2s in that.
Right.
The question is, we're now going to now have this whole, argument in our
Mhm.
multidisciplinary tumor boards in breast
Right.
about whether somebody needs a sentinel dissection or not. I think
Right.
some people may want to wait for more data. There's a really,
Right.
Mike Morrow wrote a great editorial in the New England Journal about this,
Right.
discussing. And I think that it's going to be that's a real practice changer because that
Right.
changes, if you can avoid a
Quality of
sentinel
life.
dissection, quality of life, and
Right.
then wonder about whether you should do it. Should someone go on
Right.
a CDK4/6 inhibitor? You're not really noting their nodal
Right.
status. There's a lot of stuff that's going to be involved in this going forward. And I think but it clearly is going to set a new pattern for the next 4 or 5 years
Right.
if we do this. So those are two probably
Two of
the
the
most
practice change.
practice kind of informing and altering
Right.
abstracts this year.